Yeah, now we are
Yeah,
live.
madam, we are live.
Yeah, good evening, everyone. So, welcome to this second session on reproductive immunology. So, today's topic is chronic endometritis, and I think we are all focusing on this immunology. And one of the important factors which can alter the immunology of implantation and of recurrent miscarriage, which can cause recurrent miscarriages, is chronic endometritis, especially in developing countries like India. So, this is gaining more and more popularity in terms of doing a hysteroscopy in a failed IVF cases, like implantation failures or in recurrent miscarriages. And I think this should be one of the first investigations which needs to be done rather than going in for high-end immunological treatments like LIT or IVIG or even like the PGTA. I think this is one factor which everybody can do, even in tier 1, tier 2, tier 3 cities, and the treatment is very simple. So today's topic is focused more on when to do it, how to do it, and what are the markers, that is the IHC, and how we interpret it, and how we can actually, like, give better outcomes in terms of implantation failure cases. Yeah, you can start.
Yeah. So I will straight actually share the screen. And in the time that the screen is getting shared, I want to tell everyone that don't give empirical therapy for chronic endometritis. That is not allowed. You need to make sure that when you are treating chronic endometritis, you have a biopsy proven report which is available with you. All right. Till that time, just don't randomly go and give any antibiotic therapy for chronic endometritis. And I'll explain why I just said this entire thing. So I will give you a very quick recap of everything. Everything, as Dr. Shilpa Madam has said, everything to be finishing in 15 minutes. This is the uterus. This is the endometrium. This is the embryo, as we all know, the blastocyst embryo. All right. Now, inside the uterus, when you have endometritis, that means there is some bacterial infection, some infection which is present inside the endometrium. Right. Now, in yesterday's class, just in case you were awake throughout the class, you would have realized that one of the most important things which we have to understand and study is something called as uterine NK cells. Okay. Uterine NK cells, the embryo is going to present something called as HLA-C to the uterine NK cells, and that is in turn going to allow development of spiral arterioles, okay, and invasion of the placenta. These two important things are going to be done. But in order for this to happen, the proportion of uterine NK cells has to be 10 to 30%. And where do these uterine NK cells come from? So they come from peripheral cells. That means they come from blood natural killer cells. When these boys from the blood come inside the uterus under the beautiful effect of estrogen and progesterone, they get converted into uterine NK cells. This is 1 minute history. All right. Now remember one thing, very, very important. What happens when you have infection inside? That means I am talking of endometritis. All right. What is the most common cause of endometritis? It is very simple, ascending infections. These ascending infections are predominantly going to occur from the vagina, or if I may label it broadly, from the external genitalia. This is where the endometritis is actually going to occur. And all right, whenever you have endometritis, very, very important statement and clinical point, it may or may not be associated with bacterial vaginosis. Okay, it may or may not be associated. So just keep that in mind. It may or may not be associated with bacterial vaginosis. What typically happens in endometritis? Endometritis is basically an inflammation. So now whenever somebody is getting inflamed, what will happen is the inflammation will send some marker to the peripheral blood cells. Ki, Are bhaiya, some bacteria is there. And NK cells is natural killer cells. So it does not understand anything. Natural killer cells will start entering inside the uterus. And when the natural killer cells start entering inside the uterus, the proportion of uterine natural killer cells will go down. Uterine natural killer cells will go down, and the normal natural killer cells will go up. Now, when this normal natural killer cells go up in the endometrium, along with that, they get something called as plasma cells. Basically, plasma cells are advanced WBCs, and these WBCs are going to come and kill the bacteria. That is the reason why they are present. This is the basis of doing something called as an endometrial biopsy. And when you do an endometrial biopsy, you test the endometrial biopsy for something called as MUM1. Okay. This is a MUM1 sampling. MUM1 is a very specific marker of plasma cells. And if in every high power field, more than 5 to 10 per high power field plasma cells are present, you can label the sample as an endometritic sample. Before this, everybody was doing CD138 testing, but it has been shown consistently that MUM1 is much more specific for endometritis because it is much more specific for plasma cells. So after having understood this, okay, how does it help us in our practice? Okay, so after having understood this, you have to realize that whenever there is endometritis, okay, this plasma cells, everybody is going to go and act onto that embryo, and it is going to tell that embryo कि अरे भैया थोड़े टाइम के बाद में implant हो जाओ. At the moment uterine natural killer cells are not available, there are more of peripheral cells. So what the embryo does, embryo says no problem, ठीक है, I will get implanted later, and it results in something called as implantation failure. Okay, along with that, just in case implantation has occurred, it gives rise to formation of recurrent abortions. Okay, so now very important, if you have tested the patient, the result has turned out to be endometritis, CD138 or MUM1, whatever you have done has turned out to be positive, you need to send the sample further for culture. And once you send the sample for culture, it will give you a sensitivity panel. Most of the times, there are 3 antibiotics which will work excellently well. Okay, one is doxycycline. We have mentioned this before as well. Okay, second is clindamycin, again works very nicely, and third is cynomycin. Okay, whichever one you want to use, you can use bindas. Some people I have seen, they will also add metronidazole to this. Okay, so they will also add metrogel to this. Very good. But one thing which you should never forget to add in your prescription is addition of probiotics, because probiotics is something which is going to improve the vaginal flora. And if the flora of the vagina improves, automatically recurrence of endometritis goes down. Okay. Now remember one more thing. When I say the word chronic endometritis, one of the other markers which I can use to see all these things is I can use a hysteroscope. When I use a hysteroscope, what happens in a hysteroscopy is, in the hysteroscopy, this beautiful hysteroscope is going to enter inside. Okay. This hysteroscope enters inside from here. This is the endometrium, and my hysteroscope black in color. Hysteroscope has entered inside, and you will see these spots. These spots are the same spots which I have drawn, and sometimes these spots will appear bright red. Why do they appear bright red? Okay, they appear bright red due to neovascularization, due to excessive inflammation, and that is why we may call them as strawberry spots. But remember, I am not a very big fan of these strawberry spots, because quite a lot of times in India, what will happen is automatically in embryo transfer, some people will give augmentin. Automatically before pickup, somebody would have given one shot of ceftriaxone. So in all that situation, what is going to happen and what is bound to happen is that these strawberry spots may or may not be seen very easily. That is why what you should try and focus on is something like this. This will actually appear like this. See this? And this, what you see, is actually much more specific. Okay, and this, what you see, is called as micropolyps. Okay, remember, micropolyps are not going to be seen on hysteroscope. I mean, not going to be seen on ultrasound. Best diagnosed on hysteroscopy, and it is one of the most important markers for having chronic endometritis in even cases where previous antibiotics have been administered to the patient, right? How much is the dose of antibiotics which you need to give to the patient? You need to ideally give the patient an antibiotic course for 21 days. Wait for a washout cycle. That means you wait for 1 month. And after 1 month, you go ahead and do the embryo transfer. Do you need a repeat biopsy? The answer to that question is you don't need a repeat biopsy. Okay. Now you have done all these things. Okay. And you put an embryo. And then again, you call me up and tell me, "Arey, मैंने तो अच्छा embryo डाला था, but the embryo did not implant." All right. Remember one thing. After you have done all this testing for chronic endometritis, and in this entire thing, you should never ever forget that you should almost always make sure that the embryo which you are putting inside, okay, after an implantation failure or after an abortion, should be a chromosomally tested normal embryo. That is something which is very, very important. A chromosomally tested normal embryo or a euploid embryo has an excellent chance of implantation after the endometritis has disappeared. All right. I want to also give you 2-3 more things before I conclude, and Shilpa madam can ask his questions. 2-3 more things which are very important here to understand is, apart from chronic endometritis, you will have a lot of trouble as far as the patient is having tuberculosis. And in India, tuberculosis is something which is extremely important for us to know, because tuberculosis is actually very, very common as far as India is concerned. Okay. Now, I know a lot of people are actually doing tests for plasma proteins, okay, of tuberculosis. And many a times the report for plasma proteins of tuberculosis is going to come out as positive. That, array, I have done specific, plasma protein biomarker, and plasma protein biomarker for tuberculosis has turned out to be positive. Now what to do? Shall I give the patient any form of AKT? Okay, so remember, that is basically a form of endometritis, but you need not give it, because in India, when you get plasma proteins, okay, specific plasma proteins related to tuberculosis, no big deal. It could be some antibiotic which has caused degeneration of the bacteria, and plasma proteins have been released. So don't go by that theory. TB of the endometrium, and if you have to give anything, it has to be proven on endometrial culture. Okay, and endometrial culture is at least going to take you close to 6 weeks, provided the laboratory condition is very good, because otherwise there will be contamination. All right. With this, and having said all these things, I will conclude, and I will be more than happy, because I've taken only 12 minutes. I'll be happy to answer questions for the next 6 minutes on this.
Yeah. So now you have stopped doing CD138, is it? You are only doing MUM1 or
MUM1.
So when you send it, when do you send the endometrial biopsy sample? So do you send it on which day of the cycle within the
Any day of the cycle is fine. Any day of the cycle is fine, but it is best to send it somewhere at around 20-21 days.
Okay. And what about the solution in which we send it? It is formalin, right?
Yeah, it's a buffered solution, madam. It is a combination of formalin along with HIPIS.
Yeah. And yeah, somebody is asking, can we give empirical?
No. That was my first line of the lecture. Don't give empirical antibiotics.
So in this situation, so whenever we are sending these IHCs, so do you recommend even the histopathology also for the same sample? Do you
Mandatorily, it will be done, madam.
Yeah. So mandatory it will be done. And so CD4. Okay. So right now you are sticking to only MUM1, right? I mean, that's what I am doing. I'm not doing any other thing. I'm doing only the MUM1 testing. So what is roughly the cost of this test?
Approximately, it's around 5 to 10,000 rupees.
5 to 10,000 is a big margin, So either stick to 5 or 10. It is like less than 5,000 is the cost of the test.
Yeah.
And coming to the morphological features, what you mentioned on hysteroscopy. So here we are adding IHC only to make sure that the cells of this MUM1 are seen in the sample. So what is the criteria? So they say like 5 to 8 cells are seen, more than 10 cells are seen, less than 5 cells are seen. So when do you think that we should actually consider it as a positive test and give the antibiotics?
More than 10 per high power feed. That is when you send it for sensitivity.
Yeah. What about 8 to 9, 7 to 8?
To be ignored, because then they would have not checked enough high power feeds, madam. It is important how many high power feeds they are checking. That is the first thing. Second, it is important how is the slide made. See, if the slide is made on an automated analyzer, for IHC, then all such confusion will not occur, madam. If they do manual slide preparation, then there is a problem.
Yeah. So you think, like you see a micropolyp on hysteroscopy, do you think like we can straight go ahead and start the antibiotic, or do you still want to send it for MUM1 this thing?
I will always send it for MUM1, because many a times what will happen is, we always think it is infection only, but it can turn out to be so many other things. All right. Like, for example, you can have suspicious early malignancies. You can have suspicious development of stump, which is seen on a micropolyp. All these types of things you have to rule out. You have to do that biopsy. What is the harm in doing the proper treatment?
So, sometimes you see that fluid in the endometrial cavity, and then we do the hysteroscopy, and we see these micropolyps, and we do the MUM1. It comes positive. We give empirical treatment, and then we start the FET stimulation next cycle, and again there is fluid.
Yeah. In that situation, two very important things. One, you have to rule out any cervical problem. Second, you have to rule out any isthmocele. because these two things are again very, very common to cause recurrent fluids. If that is also there, I mean, if persistent fluid is still there, then you should go ahead and do salpingectomy, because salpingitis, the internal salpingitis, then is not going to be diagnosed by any of the testing, madam, because there is no washing available for that. And then if that also does not work, then it is simply your bad luck, you know.
Yeah. So, do you recommend Mumbai testing and to rule out chronic endometritis even in recurrent abortions? Like after how many abortions you tell them to?
After 2 abortions, madam, if everything is fine, and especially if POC karyotyping is normal, then if POC karyotyping is abnormal, then it is great only, no?
Yeah. So when do you think we should do LIT? So you do this thing like the Mumbai and it
Madam,
comes.
any immunotherapy, forget LIT. LIT is one of the most time pass therapies. But any immunotherapy, the basis for immunotherapy is it has to be a normal pelvis with a euploid embryo. All right. And self cycle. Okay. These 3 things. If you are deviating, like for example, if you have a 12 centimeter fibroid, okay, chalo, 12 is too big. Let's make it 6 centimeter fibroid. If you have a 6 centimeter fibroid, what is the role of doing LIT or what is the role of giving intralipids? Just remove that fibroid, no? Right? Make it a normal pelvis with a euploid embryo first. After that has been established, all right, that is when you may think of doing any form of immunotherapies, because none of the immunotherapies have even a more than 10% benefit. None of them have more than 10% benefit, right? See, that is the reason why we see it very commonly. We all follow guidelines in Europe. Europe is completely governed by insurance, and the guideline states that if in case you have endometriosis, then no problem, don't operate. Go ahead and straight do FET, nothing will happen. Correct? That is the guideline. Now that guideline is made because if somebody operates endometriosis in Europe, I just missed out on the visa, so I know the details now. If somebody operates endometriosis in Europe, the cost of getting one surgery done in a third grade country of Europe is going to be close to 12,000 euros. That's coming to close to 10 lakh rupees. Understanding? So the insurance does not have that type of money to make those types of payouts. We follow those guidelines in a country like India. And in grade 4 endometriosis, we do LIT. Okay. If you were to simply operate endometriosis, no, so many wannabe endometriosis surgeons are available in India also now, right? If you were to simply call anybody of them and operate endometriosis, your results will automatically improve. Okay. We get carried away, but they don't get carried away, madam. They don't do immunotherapies the way in which we do it. They don't do it because their immunotherapies is decided by transplant medicine. It is not a part of gynecological curriculum. Like how it is for, I had told, we had a very nice discussion and I told you that if you have to give tacrolimus to anybody, you involve somebody who is a nephrologist or in transplant medicine. So we have been doing that with Siddharth. He is our nephrologist since almost now, I think 4 or 5 months. Every patient goes to him. He decides the dose of tacrolimus and then we administer it to the patient who is undergoing embryo transfer. That is also an immunotherapy. If I were to do it alone and something happens due to tacrolimus in every other country, my license will go because it is a transplant specialization who will give any such form of therapy, not like in India that we have seen 2 reports and we have done 1 CTC cross match, 1 abortion, and then we say, oh, come, let's do LIT. Okay, that is, I personally don't think, fortunately, we have a good viewership. So I think that amount of stupidity has to change as far as our country is concerned.
Okay, last question. High vaginal swab, is it mandatory when you think of...
How do we do a high vaginal swab, madam?
Yeah, we put a cusco speculum, take the swab from the posterior fornix deep. That's all.
And what happens if it is just a mucoid discharge there, madam?
Nothing happens. We send it for culture.
Will it grow anything?
Yeah, if it grows, it grows. If it doesn't, it doesn't.
So I think the biggest problem with high vaginal swab is the manner in which high vaginal swab is collected. Okay. See, if you study microbiology or if you have your own microbiology laboratory, you will realize this, that high vaginal swabs are actually very difficult to culture. The reason why they are very difficult to culture is because one, as you mentioned, cusco speculum goes deep inside the posterior vagina. Correct? When it goes deep in the posterior vagina, madam, most of the times you will not go and take the swab. Most of the times the swab will be taken by your assistants, right? Or a nurse or somebody or a technician.
Why? My right hand will be free only, no? Cuscus will be free the left
Arey
hand.
Baba, you are different. I'm talking of normal people like us. Okay, we don't go and take those swabs there. Okay, so you will see and you will understand that many a times the swab is coming from cervix. Many a times the swab is coming from some part of the vagina. It has touched somewhere and there is contamination. So what we have realized, and I think our microbiologist has probably made it a very nice rule, because we are trying to do something called as lactobacillus cultures for lactobacilli transplant in recurrent white discharge. Okay. And in that, we have realized, madam, that it is important to take a washing, okay, of the high vaginal swab. That means you put maybe just 10 cc of saline. Okay, you put 10 cc of saline, you rinse it out of the pouch of Douglas and you put it again. Okay, and then you take the swab. Okay, that swab gives you probably the best culture. If in case we adopt that technique, maybe in a high vaginal swab, we will start getting absolutely great outcomes. But there is one problem with high vaginal swab. Okay, in high vaginal swab, there will be so much, there will be so much bacterial contamination if the external genitalia is not good. Okay, so for somebody to take a great high vaginal swab, external genitals has to be good for 5 to 7 days, 8 days, and then the patient has to come for a high vaginal swab to get the accurate outcomes. And I think that does not commonly get followed in India. It's very difficult to follow, actually, madam.
Yeah. So thank you very much. I think this was an excellent class on chronic endometritis. I encourage everybody to find out as to where the mum testing is done in their place, and I think it is worthwhile doing it. One of my patients conceived post mum testing after giving antibiotic therapy. She was married for 8 years. I think that gives us a lot of confidence in actually like telling so confidently that these are the things that actually will add value to your practice, clinical practice especially, more than the theoretical things. And
Madam,
yeah.
I want to answer 2 more questions. Somebody has asked, and I think I forgot to mention that. What is the role of Placentrex in cases of chronic endometritis? So the answer is I don't know. And I personally think,
I give.
yeah, I said I don't know. So it must be working, it must not be working. I don't know. But there are many people like how Shilpa madam is. See, what is, I think Shilpa madam, even if she gives distilled water, no, then also people from azoospermia become normospermic. So we should not go by that. Okay. But I have seen people giving Placentrex to be given IM for 21 days. Okay, is what I think. And sometimes it may have a benefit, sometimes it may not. I have not personally used it, right? And one question has been asked by Dr. Arun Rati, that many a times you have patients who are having demonstration of recurrent mucus collection. All right. Now, mucus collection is 2 things. Mucus collection in the cervix, no problem. Mucus collection coming from the uterus, big problem. That in that situation, you should also do an HPV DNA testing from the endometrial specimen. All right. So, thank you. I think we conclude here, and more questions we can answer on WhatsApp. Yeah.